Mikrofonum açık mı? Good morning. I would like to welcome all the attendees to the fifth the online education program of the ICMAS. Let me first introduce, as according to the program, myself and my team and my department, what we are doing in Lviv Hospital and Istinya University Medical School. Today's subject is scoliosis. I'm especially interested in the spine surgeries and spine-related diseases, and the roof of the Lviv Hospital and Istinya University. We are very active, one of the active departments in Lviv Hospital Group, in the all subgroups of the orthopedic surgery and related diseases. This is my team. Each member of the team are specialized in different areas of the orthopedic specialism, the tumor surgery, the trauma, sports injuries, the spine, the regenerative medicine, arthroplasty, and foot and hand surgeries. And of course, not only the doctors, the also supporting team is important to serve the patients according to the medical standards of the world. Sorry. There are some numbers which we are doing outpatient clinics in 1 year period in Lviv Hospital, and the amount of surgeries. Our trend is increasing both from in Turkey or from the abroad neighboring countries. And as you see from the chart, is nearly half of our patients are related with the spinal the problems, which are very common, as you know, in your practice. You are seeing very common problems, and unfortunately, not so many the surgeons, not so many specialists are dealing with the spine problems. In our departments, we are trying to obey the rules of the academic environment. Of course, the treating the patients are our first aim, but publishing, the showing the academic performance in the international world is also important. We are very keen on to write the articles in our department. To the last 5 years, we have published more than 100 publications in the peer-reviewed journals. Also, in terms of the educational problem, the area, we are trying to share our experiences and teach and learn something from our international fellows. In terms of these, the field, we applied the AO Spine Center's application, also Eurospine Spine Center of Excellence, and we are happy to got this certificate. We are a Center of Excellence. This is certified by the AO Spine. AO Spine is the biggest spine society in the world. More than 100 countries, they're active in terms of educational, both online activities, the Congress, and also the fellowship program. So in the head of AO Spine, we are certified as a Center of Excellence in Turkey, and we are accepting the fellows from all over the world to teach and to share our experiences with them. Also, we have some short educational programs for 3 days, 1 week, short term, both theoretical and the practical education from our colleagues. And we are trying to serve the patients in different countries except Turkey. And those are the names of one of them. We are either going there to see the patients, to involve in the educational activities, even to do surgeries in some countries. And we accept the patients and doctors from those countries to do the medical things together. In our hospital, we are trying to use the most developed technologies to decrease, to minimize the risk of the surgeries, to minimize the complications of the surgeries. Those are the some pictures. This is robot. We are using this to place the pedicle screws in more correct position. We have these facilities. Also, we have some educational activities. We are the education center of different societies. This is the most trendy lumbar disc herniation treatment, the endoscopic close treatment. We are trying to do this in our center to teach the doctors from all over the world. Also, in our hospital, some of our the work in research. We have a very good experienced stem cell laboratory in the world standards. So we have some studies, ongoing studies and research for the regeneration of the lumbar spine, which is a common problem, and most of the patients are suffering from this the problem in the world. We have some advanced steps to reverse the degeneration occurring in the lumbar spine during the years. Another field that we are more experienced, we are the health sponsor of the famous the teams, soccer teams in Turkey. Maybe you heard the Galatasaray, Fenerbahçe. So we are following the normal health of the professional sportsmen and sportswomen, and also the injuries related with the sports trauma. We have enough experience to solve these problems and help those professional players to return their professional sports life. This is another educational activities. We are the education central of several companies. This is Alphatech Spine. Also, we have some consultancy agreements with the most famous companies in spine world, in Stryker and Maxmore Spine. Okay, this is the short summary of Liv Hospital and Istinye University, the orthopedics and traumatology medical team. Now we can switch on our today's subjects, scoliosis. It's a very large field. Probably during your practice, you are experiencing some anxious parents, some unhappy kids suffering from the problem. Scoliosis is a three-dimensional deformity of the spine, and which should be the straight in anterior posterior view, and in some kyphosis in the thoracic area and lordosis in the lumbar area in the sagittal view. This is a normal shape of the spine, but because of unknown reasons, I will mention about them. Some deformities can arise in the early ages, and these deformities can be progressive. So in those situations, most of the parents are worrying about the future of the kids, what will happen, what kind of problems it will arise in the future. And unfortunately, not so many specialists are dealing with these problems. And also, this is the most risky part of the musculoskeletal system, since it contains the spinal cord. So these kind of treatments on a non-surgical or surgical treatments carry some risk. Most of the time, these treatments have some wrong beliefs in the people. There's a huge population, there's a patient population which is unhappy, which has no hope in the future. So it may arise with some psychological problems also. This is a standard the knowledge that we know in the adolescent idiopathic scoliosis. Adolescent idiopathic scoliosis is the most common form seen on the adolescent period between the age around 10 to 20, and is progressive. Most of the patients are in this group, let's say 90-95%. The other part, the other 5%, is some specific conditions which arise early ages or in very late ages. This is called congenital scoliosis occurring in the early ages, or de novo degenerative scoliosis, which is common in the elderly population. But most of the patients that we are dealing, that you will see in your practice, is progressive scoliosis occurring in the adolescent period, teenage period. If the scoliosis degree is less, observation can be mentioned about as a treatment. Actually, observation is not treatment. Observation is just wait and see, because some of the scoliotic curves cannot progress, and very little amount of scoliosis curves can be reversed. So the observation, of course, in observation contains physical therapy, some kind of exercises. This is the first option that we are evaluating in the patients in the very small degrees. The second treatment method is brace treatment. This treatment is somehow controversial. Some of the colleagues are not believing in. Some of them are strongly supports the brace treatment. Personally, I don't believe in brace treatment because it is. I will show some literature about them. The brace treatment is not 100% successful, but as we don't know the natural history of the scoliosis, which is different in different the people, brace treatments can be done, of course, but we have to convince the patient that the brace treatment is not the 100% solution. Although the kids are in brace, scoliosis curve can progress and can need surgical treatment in the future. And the third treatment is the surgical treatment. Fortunately, today's with our newest technologies, we can treat the scoliosis with surgery. In 20 years ago, when I was a resident, we could not speak like this, because 20 years ago, the technology of the implants, or our logic, our mind is not so much as today. So in those times, the surgical treatment is also not 100% solution. But today, we can use surgery to treat these patients both physically and psychologically, and allow them to continue their normal life. Let's return to brace treatments. Normally, those are the indications commonly accepted in the brace treatments. If the patients are 10 years or older, it should be in the first developmental stages, the risk grades 0 to 2. There is some consensus that the angles, curve angles, between 25 to 40 degrees and no treatment. Unfortunately, 10 times more in females than males, and most of the patients are females. And the premenarcheal, these developmental stages is important. If the menarche occurs more than 1 year, 2 years, most of the literature advise that brace treatment is useless. So at the age of 15, 16, giving the patients with brace is somehow nonsense. There are some studies. Well, this one is the most covering studies. It's a meta-analysis. You know, these meta-analyses are more valuable studies in the literature. And according to this meta-analysis, the curves between 35 to 50 degrees in skeletally immature patients, brace treatment can be option. But although it's an option, it's advised. In this age group, its success rate is around 50%. The success in the brace treatment is not to correct curve. Success is to maintain the curve. That means if you start with the brace treatment with the degree of 30 degrees, at the end of the brace treatment, the curve is still 30 degrees, they call it successful. And this success rate is 50%. Normally, when the patients are wearing brace, of course, their degree is somehow diminished, but after removing the brace, it recovers its normal previous the degrees. So the brace treatment is not the option to correct the curve. Brace treatment aim is to maintain the curve, and which its success is around 50%. What causes scoliosis? Nobody knows. As you know, if doctors cannot know the etiology of the scoliosis or any other disease, always mention about some genetic predisposition. Yes, in scoliosis, today we know that there are some genetic events, but we don't know the details of this genetic transmission. It's not a simple genetic transmission transmitted from parents to kids. Unfortunately, we don't know this, but there are some studies. There are some special laboratories in the US. I have visited one of them. Probably scoliosis has some genetic links, but today, unfortunately, we cannot know the exact genetic events that occurred in the fetal period and causes scoliosis in the adolescent period. But fortunately, we don't know the etiology, but we know the treatment today. Of course, in scoliosis treatment, from now on, I will switch to surgical treatment, which is more complex and more things are present to be known. So the aim is to get a balanced spine over the pelvis, because the patients, most of the patients in this age period is complaining about the asymmetric position of the body in front of the mirror. And most of them are complaining with the shoulder imbalance and decompensated body. That means it's not erect, it's a right or left side decompensated. And also a pelvic obliquity. That means there is the symmetrical, the curves in the lower back. In scoliosis, it disturbs. And again, another complaint, since the scoliosis is three-dimensional, not only bending, also rotation, depending of the location of the curve in the back region, there is what we call hump. That is the rotation of the ribs make like a pseudo mass appearance from outside. So in the surgical treatment of this disease, of course, our concern, the surgeon's concern is to correct these complaining deformities from outside. Of course, the radiological improvement is also important, but at the end of the day, the patients are evaluating themselves when they look in front of the mirror. Fortunately, these curves at this age group is somehow flexible. This is the very important point that we use in the surgery. Otherwise, the curve is not flexible. We have some more difficult, more dangerous options I will mention in the end of my lecture today. So we assess the curve flexibility. So before the operation, with the help of some radiological tools, when we assess the curve flexibility, we can say something to the patients and parents about the result of the scoliosis, because they will be worried about the result of the scoliosis. Second important issue, I wrote it, is a selective thoracic fusion, but it's a more complicated issue because, you know, the gold standard posterior, the surgical treatment of scoliosis is fusion, I will mention today. So fusion is gold standard, but it's not natural. In the thoracic spine, yes, there is no movement, so fusion, it doesn't matter. But in lumbar spine, and some of the curves extend in the lumbar spine, and if we fuse the lumbar spine, we are in fact losing the mobile segments we are sacrificing the mobile segments in terms of correcting the scoliotic curve. So the level of selection in the distal level is very important. It should be precise because it should be the last surgery of the patients. It will not decompensation in the future, but we have to be careful as much as possible to save the mobile segments in the lumbar spine again for the future, the life and health of the patients. And the third point, key point, which is most of the time missed from the specialists, is the limb length inequality, because it has relation with the scoliosis. As you can imagine, it's a mechanical structure. If there's a problem in the pelvis or in the leg length discrepancy, it will directly affect the spine. So some of the scoliosis is which is mild scoliosis. Some of the scoliosis is related with these deformities. So when we evaluate and treat the patients, we have to know the current condition of the pelvic structures and also the legs. As you know, for the curve flexibility, there are many different radiological tools. Of course, there are some articles related with the more X-ray can cause more breast and over the carcinoma in the future. So we should be careful while using the modalities. But standing AP and standing lateral are the graphies are the gold standards. There are some described different techniques to determine the flexibility of the curve, which is spine bending, spine traction, fulcrum bending. We have some studies about the traction X-rays under general anesthesia. Of course, it depends on the patient's curve and depends of the surgeon's experience and depends on the expectation of the patient's family and also and patient. This is one case example, and the standing AP X-ray shows more than 100 degrees curve, and which is a 16 years old male patient, and only standing AP X-ray shows it's quite rigid. But when we use these flexibility graphies, they show it's not so rigid. So according to the standing AP, probably we can think about the kind of osteotomies to give the flexibility, but these patients took only posterior instrumentation and using this flexibility correction of the curve. So knowing the flexibility of the curve is guide us to select the type of surgery that we are doing, and so we prepare ourselves before surgery to help more the people and to take the risk less, of course. This limb length inequality relation, all pelvic girdle, there are several studies. Everybody knows, of course, one of the leg is short, it will make a pelvic imbalance, and to compensate this pelvic imbalance, the spine should bend. This is scoliosis. This in the starting, in the beginning of the problems, it's mild, but if we cannot recognize this problem and cannot correct the limb length differences, then this beginning compensatory scoliosis in the following years can return itself to the structural curve, and which needs more complex treatments in the future. We have some studies we have published in the literature, limb length inequality, the sacral tilt, that means the tilt of the S1 is important. And in the scoliosis patients, 74% of the patients have sacral tilt. So definitely we cannot say 100%, of course, but probably the sacral tilt can be a major predisposing factor for the development of the development of the scoliosis in the future. So if we can catch the sacral tilt in the early ages and with related examination with the limb length, length differences, by equalizing either surgery or by external means, we can prevent, this is an idea, this is theory, we can prevent this scoliosis, some of the scoliosis at least. You see, this is 12 years of female with scoliosis of lumbar curve, major curve, needing surgery. And you see this is sacral tilt S1. And of course, knowing this sacral tilt pelvic obliquity is also important because in these patients, we are trying to serve the mobile segments in the lumbar spine, I will mention. So leaving the low lumbar spine uninstrumented also takes the carries of development of the scoliosis more. But the fusing the all lumbar spine is another big problem. So these examinations should be done before the surgical planning of the patients. There are some different examples. The legs are different in length. There's some more examples here. This is a very small kid, you know. It's infantile scoliosis, very small, 2 years, and sacral tilt is present. Also, even at this age, there are 7 millimeters length difference in the legs. Another example, it's a very small curve, but if we cannot correct this pelvic obliquity by external means, by the way, there is some expression, okay. This curve, this mild curve can progress. You see, this is the left-hand side is a curve, which is the border of the brace treatment or surgery. The patients are 14 years old. The parents are asking what will be happen in 1 year ago. It's very difficult. But if this is 2 centimeters limb length inequality, you see the pelvic tilt, giving only height, 2 centimeter height with the left foot is significantly correct the scoliosis. And at this part, the patient is in the border of brace treatment or surgery. Now patients go down into the observation group. Or brace can be treated, but it's less. So leg difference is very important to recognize. Also, this difference is important in the after surgery. You know, this is 18 years old lady, 50 degrees of lumbar curve. We fix it, correct it. In the middle X-ray, you see, or during the operation, while the patient is supine position, everything is okay because leg difference has no issue in the supine position, and we stop the surgery. We finish the surgery. After the surgery, in the control X-ray 1 week after operation, you see there's a total body imbalance. Of course, the patients is unhappy. We are unhappy because we make a lot of efforts, but the result is this. Those are all experiences that we learned from our previous patients. When we measure the leg difference after surgery, we found that 1.5 centimeters difference. So when we get the height just on the heel of the foot in the shoes, this is the result. The body is compensated and the patients are gaining the exact benefit of the surgery. So limb length inequality is very important. Digital CT is the main tool, but please concern about the radiation. And for the sacral tilt, Ferguson X-ray, because normal X-rays cannot show this obliquity. Ferguson X-rays are important. And as I said before, these examinations will affect the treatment plan. As I mentioned before, the most important issue in the surgical treatment of scoliosis is to select the most proximal and most distal level, because it should be correct not to compensate the curve in the future, but also it should be as less as possible to save the more mobile segment, especially in the distal part. In the proximal part, it is important for the shoulder balance, which is the main complaint that the patients are suffering at this age group. Normally, the selection is to fuse the curve from the cranial neutral to the caudal neutral vertebra. Neutral vertebra is the vertebra in which there is no rotation. But unfortunately, there are the several types of curves. According to the Lanke classification, there are more than 52 types of curves, and this basic information cannot work in some of them. So we need more criteria to select this fusion levels. As I said before, in the selection of the proximal fusion level is important for shoulder imbalance. So we select the level. Of course, it should be as low as possible, because when we go up to the neck, the patients can suffer from neck pain after operation, and this balance the position, flexion position in the sagittal plane. So, but if we don't go enough up proximal, and just to save the patients of these complications, then the shoulder balance imbalance can continue or reverse, and patients are still suffering after this huge operation, still cannot like your body in front of the mirror. There are some criteria. Several authors describe this. Seo Suk is a very famous Korean spine surgeon. He's so clear. If the proximal thoracic curve is over 25, fuse the proximal thoracic curve. That means fuse up to the T2. This is the oldest theory. When it published first, many surgeons are against this criteria. But now, today, in my the practice, I'm strongly supporting the Seo Suk. If the proximal thoracic curve is over 25, we have to fuse T2, because with our powerful implants, we correct more in the thoracic curve. When we correct the thoracic curve, as you can imagine, the upper thoracic curve can progress. So we have to do something. We have to have anchor points in there, so to reverse this corrective mechanism. The Lanke group divide structural and non-structural. According to them, if it's structural, that means over 25 in the bending, fuse it. If not, it cannot fuse. This is an option. Again, another the publication from the same group, we are normally looking at the operation is the T1 tilt, because T1 tilt is we believe T1 tilt is the best criteria to show the shoulder balance. But now, after these publications, the clavicle levels, first rib levels, is more the corrective. And also there are some articles that publish after these operations. In the time of finishing surgery, although it's not balanced, some authors supports that with the end of 6 months, the shoulder balance can occur itself. It's a compensation mechanism. So this is another issue. The shoulder balance seen clinically is not the same shoulder balance seen in the X-ray. That means sometimes in X-ray, all the clavicles, first rib and T1 tilt is balanced, but in the clinics, patient is suffering from this shoulder imbalance. It's a very complicated issue. In my the practice, I'm always waiting at the end of 6 months, and I'm always saying to patients, this is not the final position of the shoulders. Wait for the 6 months, if I am convinced that the radiological criteria is balanced. I'm skipping this. This is some case examples. We have published this in Eurospine the recent years, and the stop at T2 in most of the cases is mandatory, unfortunately. And not so many patients are suffering from this neck pain. They are somehow used with the forcing them to exercises for the extension exercises. We can compensate these actually. And the distal fusion level is more important, more complicated because in the up there is no fusion. The only concern is the pain in the neck region, but in the low, it's not the issue. The lumbar spine are mobile spine. Lumbar spine will carry the weight of the body all over the life. You know, even the normal spine, normal lumbar spine, not scoliotic, normal lumbar spine can degenerate when they become older. So if we fuse some of the lumbar vertebra, we can decrease some kind of movements, some kind of flexibility. Also, we leave the unfused segments alone to become more prone to degeneration in the future life. It's a very the complicated issue. And on the other hand, we have some aims. The patients and family are some expectations and the result of surgery. So we have to fuse enough segment as much as possible to guarantee that the curve will not be compensated and the patient will not need any more surgery in the future. This is two dilemma we have to solve by weighting the two concerns at the same time. The most famous classification in the classification of the scoliosis is Lenke classification. This is the most recent one. Although the later Lenke, which is my friend, it's also against some part of his classification because this scoliosis cannot be easily classified. And second thing, the classification is, as you know, is the talking the same language between the physicians. Normally, we cannot guide our treatment plans 100% according to the classification. So the experience and the curve of the patients, the expectation of the patients are more important. But according to the classification, we have to advise some kind of treatment. This is Lenke type 1A, 1B, main thoracic, which is most commonly seen in the adolescent age group. There are some terms, as I mentioned, this is stable vertebra, stable minus vertebra. In this Lenke type 1A, 1B is main thoracic, the main curve is thoracic region. This is the most ideal curves for selecting selective thoracic fusion. Selective thoracic fusion as a spine surgeon, most of the spine surgeons like the selective thoracic fusion because we don't disturb the lumbar spine, which means the mobility, degeneration risk, we are out of these complications. We like in terms of this, but and also the most afraidable technique is selective thoracic fusion because the selection criteria is not so clear. So if you select in wrong way the selective thoracic fusion, lumbar curve will progress, and in the near future, the patients can start to decompensate, and the end result of your first surgery will be failure. You will fail, and patients needs another operation, which has some physical and psychological problems with the parents, patients, and the physician. So if type 1A in the left-hand side is definitely selective thoracic fusion. In type B, you see there are some lumbar curve also, but it is compensatory curve. And there are many articles say that in these compensatory curves, if you fuse the main curve, that means the thoracic here, lumbar curve spontaneously result, which is seen in the patient's X-ray in the right-hand side. Type C is somehow more problematic because it is very difficult to decide the lumbar curve is structural or compensatory. Probably it's not two different things actually. It starts as a compensatory curve when it reach some degree, it converts the structural curve. To make the difference between structural and compensatory is the bending X-ray. You see in the bending X-ray, 38 degrees converts to 10 degrees. So it is probably non-structural, compensatory. So at this age, although in this curve, although the classification says 1C, which is commonly advised to fuse both curves, we can try the patients with selective thoracic fusion without disturbing the lumbar spine. Of course, for the selective thoracic fusion, there are some steps we have to obey and we have to share with the parents. First one, always we have to mention about the possibility of the progression in the lumbar curve, and the patients may need some kind of extra surgery in the future. This is important. Second thing, to control the compensatory curve is somehow can be difficult. So the patients can wear brace some period after the operation, which is also a surprise for them. And the third thing is related with the surgical technique. I will mention in the later, but in selective thoracic fusion, we have not to correct the main curve maximally. We leave some part of, as you see in the right-hand side, we not 0 degree, 10 degrees, because to compensate the lumbar curve. Otherwise, if we correct the thoracic curve 0 degrees, 100% correction, then this compensatory thoracic lumbar curve can progress. This is is different, is strange for you, but there are many articles related with this. Yes, this is the indications. If thoracic curve is more than lumbar curve flexibility more, that means it's compensatory. The third important thing is there should be no kyphosis in the thoracolumbar junction. Normally in the thoracolumbar junction, in the sagittal plane, it's straight. In the thoracic part, kyphosis, lumbar part, lordosis, it's a transition zone, so it should be straight. But if it's a kyphosis, namely is more than 10 degrees, stopping at the apex of the kyphosis in the T12 or L1 is cause adjacent segment problems. So it's a contraindication if there's a kyphosis, although the AP plan shows advise us to do selective thoracic fusion, we cannot do selective thoracic fusion. We have to go over this kyphosis area to down into the lumbar spine. There are some old examples of selective thoracic fusion with the oldest implants. You see these patients with 55 degrees of lumbar curve. At the end of 9 years, again, 50% correction, but the patients have a balanced spine and is happy. And we have published in some of the SRS, the meetings. Now, Lenke type 2A. This is also, according to Lenke, is a double thoracic curve. Its selective thoracic fusion is more challenging in this age group because in this curve type, but again it can work. So as you can understand from up to now, if we can have option to do selective thoracic fusion, use it. If we have no enough experience to correct this deformity with selective thoracic fusion, then going down to the L5, the L3, L4 is not a disaster, is not a catastrophe. We have 2 publications related with this, published in Spinal Deformity Journal last year. Although we stop at L3 and L4, the remaining disc will not degenerate so quickly. It's a 10 or 15 years follow-up study. Of course, we don't know when 30 years after what will happen, but leaving the spine with the scoliotic curve is more important to cause more degeneration because of the asymmetric loading of the lumbar disc in the future. Type B. Normal type B, the recommended treatment is fuse both thoracic and main curves, but we can try selective thoracic fusion. It can work, I can say. Type C curves, again, it's a very big adventure to take a selective thoracic fusion. It's a very old example from my first years. I was more courage in this cut, but now in the type C curves, in double thoracic curves, in the compensatory lumbar curves over 50 degrees, I fuse the lumbar spine also. Lange type 3 double major curves. Again, selective thoracic fusion is somehow adventure, but can be tried. But in these curves, going down to the lumbar spine can be a reasonable option. Type 4C, of course, selective thoracic fusion is a huge curve. Selective thoracic fusion is not the option. Type 5C is a very different curve. Normally, in the publication of the Lenke in the early 2000 years, he recommended the anterior surgery for them. Personally, I have no experience with the anterior surgery. It looks me a more aggressive and more debilitating surgery for the kids. But at anterior surgery, of course, you can do fusion from the cup level to cup level. So to say, you can say more motion segment distally in the lumbar spine, which is the main important issue for us. This is one anterior surgery. Very good. But when I was working with Professor Hamzoğlu in Florence Nightingale Hospital, Istanbul Spine Center, we were always thinking about can we do the same surgery from posterior? That means the same levels, because from the posterior surgery, the recommended part is to fuse more segments. And the answer is yes, we can. So instead of anterior surgery, we can do the same level posterior surgery and short segment fusion in the Lenke type 5 curves. And type C curves is the most common curve that we are seeing in the daily practice. In these curves, for the thoracic part, there is no suspicion to fuse. But in lumbar part, normally, as you see from here, the recommended part, stable vertebra, is L4. That means the mid-sacral line cross or touches L4. Normally, it should be stop at L4. But if we stop at L4, we leave only 2 mobile segments in the distally. So in these patients, with the help of some kind of flexibility graphies taken in the operation, we hypothesize and conclude that in these patients, we can stop at L3 in L4, not disturbing the balance of the spine. But of course, we gain one more mobile segment, which is very important for the patient. So these Lenke types 3C, 4C, and 5C curves, we can stop in most of the patients at L3 instead of L4. According to this part, this is the basic theoretical knowledge about the adolescent idiopathic scoliosis. Now, in the next part of this educational program, what we are doing in the operation, I will show you with the help of some surgical videos, and the second half of last part of the operation before question and discussion and question part is not, fortunately, all these kind of curves are so flexible. We have some severe curves, severe complex the curves with intraspinal abnormalities. So these flexibility maneuvers, corrective maneuvers cannot be enough. So what we are doing to give more flexibility to the spine, this is called osteotomy, types of osteotomies. Also, I have prepared some osteotomy surgical videos in the technical. Some of the attendees can be interested in the technical tips and tricks. And the second part of the program, I will mention about this. then let's take although it's late, early, let's take a 15 minutes coffee break, and in 10:15 we will start the video session. And I will take all the questions and discussions at the end of the lecture. Thank you.
Ben ara verdim. Sen dinlemiyorsun. Neyi? Dinlemiyorsun. Kesiliyor hocam ya. Ben ara verdim. Çekmiyor. Ben ara verdim. Sen şey yap. 10 çeyrekte geliyorlar başta. Tamam. 11 buçuk yüzden de o biter. 12'ye kadar soğutma lazım. 12'de bitirir diyorsun. Soru gelmezse zaten. Soru gelirse konuşuruz. Ben uzatacağım da neyi?
Beni mute yapmış olabilir mi? Ben kendime yapabiliyor muyum?
paylaşmışsınız ya.
Önceki şey paylaşmıştım. Evet, şu.
Değil mi?
O. Kaldığımız yer. Okay. Okay, welcome again. Now, in this part of the lecture, I will show some surgical videos and techniques. This is the name of the lecture, Tip and Tricks. If some of the attendees or most of the attendees are willing to do these surgeries, which is not so complex surgeries, we can you can benefit this some tricks that I have gained throughout the year 20 years of experience. Now this video is the patient is lying in the prone position. This is the head, the proximal part. This is the bottom, and I'm in the left side of the scoliosis. And in the exposure, to decrease the bleeding of the exposure should be subperiosteal. And this is my way. I am start to expose from down to up in the left side of the patient, and start the exposure from up to down in the right side. This is the orientation of the muscles. If you obey this, bleeding will be really less than normal. From bottom to up in the left side, from up to down in the right side, and subperiosteal. And my first exposure, when I was a resident, just during exposure, the patient took 4 units of blood. Now we are using only 1 unit of blood the whole operation today. This is some kind of the experience and doing more and more. This is the patient, the major thoracic patient. This is lanky type 1A. So our plan is to do only diffuse the thoracic curve. We call it simple scoliosis. Now this is the pedicle screw replacement. Normally in my practice, I'm using freehand technique, which is more suitable for me. In the thoracic spine, the anatomical marker is very clear actually to put a freehand pedicle screw technique. Now I'm taking the facet joint here. This is, again, I'm repeating, this is up, this is down. I'm in the left side of the patient. And this is around thoracic 12, or sorry, thoracic 9 or 8, 9 or 10. I'm first making a, let's say, the hole with the pedicle finder. If you are in the right position, the pedicle finder finds its way in the spongious bone. So it's in the young patient, it's very difficult to violate the lateral and the medial walls and the upper and the lower walls, because it is quite stiff. This your pedicle finder shows some resistance if you are in the wrong direction. Of course, before the operation, you have to memorize the X-ray of the patients, at which level, which degree of rotation is present. So to place the pedicle screws according to the route that you created. Of course, I am using, actually it's the gold standard. All of these kind of surgeries are done under neuromonitorization, which is a quite safe technique. Neuromonitorization technician is in front of the computer and make the electric signals, send the electric signals, and take the responses so they can evaluate the position of the nerves and the spinal cord. Of course, during the neuromonitorization, the neuromonitorization technician and the anesthesiologist should be in good cooperation, because when the anesthesiologist gives muscle relaxants, it's impossible to get the neuromonitorization. There are some ways the anesthesiologists know these ways. So during the operation, the signals should be apparent, and at each step, during pedicle screw fixation, during correction, or even doing osteotomies, neuromonitorization technician is the most valuable person in the operating theater. Now we are placing the pedicle screws. Normally, these spinous processes can be done or can be leave, but the interspinous ligaments between the spinous processes, it's better to remove them to gain more flexibility. Also, the facet joint, taking the facet joint before correction is also useful, both in terms of two ways. One is to make the fusion area, to provide the fusion area, and also taking the facet joints gives more flexibility and it helps the correction during the operation. So after placing the pedicle screws and check them with the X-ray or fluoroscopy that they are in place, and if you are sure, then the most enjoying part of the operation is to correction. Normally, for this curve, there are several correction maneuvers. They are named at the heading of derotation, global derotation. I will do now in the video. I will show it. Segmental derotation. If you are doing all segments pedicle screws, which is my way. Segmental derotation, because in global derotation you cannot correct rotation 100%, so segmental derotation is also important. And also another one is cantilever technique, which I'm not using because in cantilever technique, if there is no rotation component is prominent in the scoliosis, you can use cantilever technique, but most of the scoliosis requiring the surgery has some kind of rotation. So cantilever technique in the presence of the rotation is somehow not enough, is weak technique. Now we are placing, always start the correction with the concave sides. This is rule for the thoracic spine. And if your main curve is lumbar, which is not in this case, but in lumbar, also start the lumbar correction from the convex sides. This is the orientation of the rotation. So correction maneuver will be more precise in this part. Now we place the first rod in situ. That means no correction maneuver. Just place rod as it is when the supine is correct. And we are placing the set screws. These set screws should be loose, not fixed all over the operated area. All set screws should be loosed. Again, I'm repeating for the new one. This is head, this is tail. I'm in the left side of the patient, and this is the concave side of the curve. This is the convex side of the curve. Now I'm placing the set screws. There are some tools, in the instrument sets to adjust the set screws to the screws. But of course, these adjustments maneuver always makes more force on the screws. And if your screws are not so strong enough, it can cause some kind of pull-out problems. So we should be careful. Sorry. Now, after placing the rod, you see there are some strong rod holders, which is very strong. We place two of them around the apex. You can do it from the apex or around the apex. This is the global derotation maneuver. According to the bending signs of the curve, and according to the you see with naked eyes that the rotation is disturbed. You see this is we correcting the scoliosis in the reverse position. And when we do, you see this is the global derotation maneuver. When this bending sign is in the just in the signed area is 90 degrees to the ground, you stop it, and my way is to fix the apex and most distal one. Mostly recommended part is only fix the apex. Anyhow, we have to fix at least one. Now I'm doing the apex. The apical vertebra can be determined from the X-ray or during this operating position. So when you remove this this rod holder, you see the curve will not be reversed. It is fixed and rotation. Now, after this step, we switch to other part because we have another correction maneuver for the fine adjustment. To do this, we have to fix the other side. Other side rod placement will be quite easy because there is no rotation, there is no curve anymore. Just we should be careful in the right side. That means the convex side is to give the adjustment to the rod according to the enough suitable kyphosis and lordosis. In most of the adolescent idiopathic scoliosis in the major thoracic curves, there are some hypokyphosis, and most of them the kyphosis is less than 20, which should be around 40. So we have some titanium rods and also more stiff chrome cobalt rods. So the adjustment it should be according to the rod. So bend the rod according to the desired position, desired kyphosis and lordosis degree, and adjust rod to the screw is the best way. In some cases, if this flexibility is not enough, we can remove the rib heads in the apical part, so it gives more kyphosis gain, which is, you see this is a rocker to make a force in the screw, but if you are thrusting in screw, you can use it easily. And every step, every 5 minutes, every 10 minutes, or if you are suspicious, anytime, say the monitoring technician took the signal, and it gives you the confidence and happiness that everybody is on way, then you can go them. So after fixing the rod, the other side, convex rod, it is 100%, not 100%, sorry, it's around 80% corrected actually. Now, after this point, in this simple flexible scoliosis, we have some fine adjustments. You see they're not level. So this is segmental derotation maneuver. There are some tools in some the company's implant sets, but easily in every implant set, this can be like this. Here, let me stop it. Here, this is the concave side. This is the convex side. So in segmental derotation, you see it is the more medial position, should be more lateral. This is more lateral position in the convex side, should be more medial. This is the segmental derotation. It should start from the apex, one and down, one and up, or it should be first up, down. It doesn't matter. This is the segmental derotation maneuver. If your facet joints are taken, if your interspinous ligaments are off, if your curve is flexible, then it is very easy to segmental derotation. And at the same time, imagine this convex side is more short, so we can try to balance these two levels with doing distraction. The recommended distraction maneuver should be done, as you can imagine from here. Normally, doing compression from the other side is not recommended, because if you do distraction here and compression here, the total body can compensate to the right side, to the convex side. So do it whatever possible in the concave side, and adjust the convex side to the concave side to the convex side is the most preferable correction maneuver. You see what we are doing now in segmental derotation, then distraction. This is distraction in the concave side, starting from the apex down one by one and up one by one, distraction. This is the lowest instrumented vertebra. Of course, in the lumbar spine, which is not in the case, but in lumbar spine, Destruction is not so good because destruction decreases the lordosis. So in lumbar spine, again, instead of destruction, we have to do compression from the convex side. Destruction in the concave side, compression in the convex side. Again, one level above the apex, again, segmental derotation. Maybe you see this is the lamina is moving and find its in its final position here. Again, fix it and some kind of destruction. Yeah, this is a true way. Yes. The apex vertebra, which is the first fixed vertebra, is guide. You see, there's still these two are not level. So doing this is segmental derotation, and destruction will be level. And before destruction, we have to fix the part in the convex side. This is destruction. By the way, look at here, it's not level. So we destruct it and make a level here. You can check it during fluoroscopy. If you have facility to take an intraoperative X-ray, it is another option. It can be done. And then you see here in the left-hand side to correct the deformity in the concave side. Again, this is segmental derotation, can be done every level, every 3 level, every 4 level. But since we are dealing with the segment derotation, it should be 1 level. This is the more logical one. And destruction maneuvers that we did. And this is the end result. This is one problem which is not in the video. While doing destruction in the concave side, leave the uppermost two not destructed and wait. Then during the operation, my practice is to take an X-ray or by fluoroscopy, because when you correct this curve can be can increase the shoulder and T2 to in the reverse direction. So in the in the most proximal part, we can do compression instead of destruction to level the shoulder balance. It should be done after seeing the fluoroscopy level, which should be easy. There are some case examples doing this correction. This is the basic correction maneuver which is done, and also in my practice I'm doing. And this is some example of selective thoracic. Those are different patients, selective thoracic fusion. This is adult. In the early adult, young adult, let's say, the mechanism is somehow the same. The only difference in the young adults is they are less flexible, of course, when you compare to the adolescents age group. This is another the example. There are several examples like this. And you see this is a selective thoracic fusion. Although the X-ray shows not 100% straight spine, you see the clinical, it's not so matter. The important thing is shoulder balance and waist asymmetry. This is another patient. Some revision patients. Now, if the curve is more rigid, unfortunately, not all patients are applying to us or applying to doctor in the early period, like the case that I showed before. Most of them are severe rigid curves, so we have to do more. We have to do more things to gain more flexibility. Intraoperative hollow femoral traction is one way, although it's a very aggressive way, but it works. We have published the results in the literature. Intraoperative hollow femoral traction is like this: in the supine position, make a halo. You see, this is halo. And femoral traction, and most of the orthopedic surgeons are familiar to do this femoral traction, you know, from the femoral and hip fractures. And during the surgery, of course, under neuromonitorization, gradually increase the weight from the head and the legs up to 30–35% of the body weight. That means if the patients are 50 kilograms, then you can add up to 15 or 20 the kilograms, but of course gradually, slowly and under neuromonitorization. The only contraindication in using intraoperative halofemoral traction is chiari malformation. If there's a chiari malformation preoperative in our preoperative MRIs, then these techniques we cannot use. It is harmful. Otherwise, and of course, if there is also, there should be no intraspinal abnormalities like tethered cord or diastenotomy area. And it's a very quite safe technique, and it helps the surgeons to gain more flexibility in the severe curves. This is, for example, the case example. Normally, this X-rays is a very severe curve. The patients are 13 years old. The only good thing in this patient is 13 years old. So we have some expectations for the flexibility, but it is more than 100. Normally, seeing the normal standing X-ray in the left-hand side, most of the spine surgeons can think that this patient needs osteotomy, but intraoperative halofemoral traction is enough. Let me X-ray. This is only the result of the intraoperative halofemoral traction and made a wide facet resection, interspinous ligament removal, and making those correction maneuvers that I have showed before. And this is the result. And clinically, the shoulder balance, the waist asymmetry, all of them are acceptable. And these patients escaped from the risks of the complications of the osteotomy surgery, of course. And second part of this section is osteotomies. Of course, the osteotomy is the master degree of the spine surgery, because we are dealing with the dangerous part of the musculoskeletal system. And with osteotomy, we are trying to remove some part of the vertebral body without touching the spinal cord, without disturbing the biomechanics, the vascular supply of the spinal cord, which cannot be seen directly in the operation area. But of course, in some deformities, if we are keen on to correct the deformities, we have to do this kind of the osteotomies. There are basically four types, from simplest to the more complex one. One is the posterior column osteotomies. It's like, call it Ponte osteotomy, Smith-Patterson osteotomy, Chevron osteotomy. Actually, they have small differences, but all logic is same. As you see, is the vertebral column is three-column theory, and these osteotomies deal with only posterior column. So as you can imagine, it is quite simple, but if it deals with the only posterior part, its corrective capability is less. The second, the one more aggressive, is pedicle subtraction osteotomy. In pedicle subtraction osteotomy, I will show the examples. We are dealing with more in the middle column, so it gains more corrective capability. The third is bone-disc-bone resection. This is the actually anatomical advantages of the spinal cord without disturbing the nerve roots. Between the two nerve roots, there will be area with bone, disc bone. So removal of these parts can correct some coronal, if you do asymmetric, and sagittal deformities at the same time. And the final degree, this is the last year lesson that we learn in spine surgery education, is posterior vertebral column resection. This posterior vertebral column resection, if one surgeon can do posterior vertebral column resection, this is the most difficult, most complex, most needing experience type surgery. Of course, the gain of this surgery in terms of flexibility of correction is more, as you can imagine. In European Spine Journal, we have made a review article and described in detail in the advantages and disadvantages, tips and tricks of all these osteotomies. I think the publication is open access publication, so you don't need to be recorded in the journal. You can directly reach from the internet, and you can see and you can read. You can see the pictures on the detailed techniques of these kind of osteotomies. Let me first see the one by one. The Smith-Patterson osteotomy, that means chevron posterior column osteotomy. Maybe you know, this is the V-shaped osteotomy. That's why we call it chevron osteotomy. If it can be done in asymmetric fashion, that means more here, less here, it has some advantage to correct the scoliotic deformity, but main usage of the Smith-Patterson osteotomy is to correct the kyphosis. You see, if there's a kyphosis in Sherman disease, for example, or in sharp post-traumatic kyphosis, if you do this osteotomy and doing compression here and close this osteotomy, it corrects the kyphotic deformity. It's a very old osteotomy, quite simple osteotomy. The osteotomy only of the only posterior elements, as I said before. Of course, there are some necessities if your disc space should be mobile. That means in the anterior, the middle column and the anterior column, it should be in normal anatomical position. Otherwise, with the help of the posterior compression, we cannot move, you cannot close the osteotomy. So the one important necessity of this doing this Smith-Patterson osteotomy is to do mobile disc space at every level in the osteotomy site. As I said before, it's a simple osteotomy, but its correction gain is less. In one level, around 10 to 15 degrees we can gain. So if you do more than one level, I will show some case examples. In the total, you can gain good correction without risking any spinal cord problems. Of course, secure segmental fixation is important in every type of osteotomy, because in the after doing osteotomy, you are trusting on your screws, because everything in the correction and closure of the osteotomy, your main support is pedicle screw. If these pedicle screws are not strong enough, it's not on the right position, then you will be at trouble to pedicle fracture, to pull out of pedicle screws, damage of the nerves, spinal cord, to change the plan. Everything will be chaotic. So before any osteotomy or before any correction maneuver, let's say, you should be assured yourself that your pedicle screws are in the right position and is strong enough. Case examples. For example, this is neuromuscular kyphoscoliosis, but the kyphosis component is more prominent, but there's also scoliosis. So as I said before, in this type of patients, if the anterior disc space are open, that means the discs are mobile. And in some flexibility graphics shows it's somehow flexible around 50%. By using asymmetrical Smith-Patterson osteotomies, that means more in the convex side, less in the concave side, can correct both kyphosis and also scoliosis. This is 3-level scoliosis, T8, 9, 9, 10, 10, 11. This is the clinical pictures before and after the operation. Of course, this posterior column osteotomies can be used in more complex revision cases, iatrogenic kyphosis. For example, this patient has some laminectomy previously. Especially our neurosurgeon colleagues are like this kind of extended laminectomy without instrumentation. In the short term, it can solve the problem, but in the long term, as the child grows, it causes iatrogenic kyphosis. So at this part, the instrumentation should be necessary. Osteotomy, after osteotomy, adjacent level, we will do Smith-Patterson osteotomies and the correction of the deformity, you will see. Another patients, 10 years old, male patients. These patients came us from Macedonia, I think, Skopje. And this is the X-ray of the scoliosis. It's more than 20 degrees, very large curve. Scoliosis component is prominent, but there is also kyphosis. I'm always in the preparative planning. I'm always doing CTs and MRIs. Although the curve is typical, I'm using MRI. I have published this in International Orthopedics in around 10 years, maybe more ago, because most of the recommended MRI usage is if there is a atypical curve or any neurological problems. But as in these publications we published, although the curve is typical, and the patient shows no any neurological problems, around 8% intraspinal abnormalities can be detected in MRI. And this should definitely change the surgeon's behavior during the operation. So the routine MRI examination and routine CT examination is mandatory in my practice in the evaluation of all types of curves, not only severe curves, all types of curves. You see there are severe curve, but as you can differentiate from the CTs, the disc space are mobile. That means it's not a congenital problem. There is no fusion here. The disc space is somehow wedged, but it's mobile. So we decided these patients a kind of osteotomy. Sorry. This is after placing the pedicle strip ribs, the wide resection of the facet joints. And this is the first step of doing Smith-Patterson osteotomy. We remove the facet joints, we remove the spinous process, the tip of the spinous process. Then beneath it, we will see the ligamentum flavum. With the both ends is the facet joint, the surface of the lower vertebra. Then we remove the burr with these facet joints. So totally from one side to other side, there is no bony connection. We will check it with the blunt tip dissector or the hook that there is no bony connection. Then you complete the osteotomy. This is osteotomy. You see here like this. I'm placing the Surgicel here because of bleeding, because epidurals bleed, like unfortunately here. And if we are planning to do one more level or 2 levels, 3 levels, you can jump to other levels. Since the anterior column and middle column is intact, in the doing Smith-Patterson osteotomy, there is no need to place a temporary rod because we are not afraid of any translation or any other different movements in the upper and lower segments in the osteotomy site, which is the concern in the other osteotomies. I will show it. So safely you can do this Smith-Patterson osteotomy at every level, of course in the thoracic part, because in the lumbar part it gives more lordosis. And the other logic of the operation is same actually. Anyhow you have some flexible spine in front of you, so the placing the rods, you see first place the concave side, then place the convex side. One difference from the previous patients is a normal scoliosis without osteotomy. Global derotation maneuver is somehow risky in Smith-Patterson osteotomies. And second difference from them is, since our aim is to close the osteotomy, so any destruction maneuver is against this aim. So whatever you do should be on compressive side, so shorten the spinal column, because here you are actually cutting the link between the upper and lower mechanical bone block. So any destruction maneuver can destruct also uncontrollably to the spinal cord, and the destruction of the spinal cord is a disaster. Definitely its vascular supply is disturbed and it can cause a sudden paraplegia during the operation. What we are doing, we have different instruments. This is the coronal bending instrument. In the coronal bending, you see it shortens the spinal column. We are doing in the convex sides. We can do same thing from the other side to the concave side. These are quite shortening, spinal cord shortening processes. Please be on mind in the osteotomies, any kind of osteotomies, our enemy is distraction, because normal in spine distraction can have some limits. You cannot distract a couple of centimeters, but you can in the osteotomy, which is very dangerous. You cannot stop it. So whatever we do, we have to do from the convex side to in terms of compression and this coronal bending to shorten the spinal column. It is important for the fate of the spinal cord during the operation. And this is the end finishing of the operation. After finishing the correction, of course, most of the patients, as I said before, suffer because of the rib hump. So we can remove the hip, called costoplasty, and up to 5 ribs we can remove. In fact, removing only 1 or 2 ribs will not give enough cosmetic benefits to the patients and surgeon. So at least 4 or 5 the ribs, this curved part of the ribs can be removed one side. It will only deteriorate the pulmonary function in the early postoperative period, but the literature says at the end of 2 years, this pulmonary function recovers. And also you can use these ribs as an autograft in the osteotomy site. This is the end result. It's quite balanced. The shoulder are balanced, the pelvis are balanced, which are the main gains of this operation. And this is a clinical picture after operation, very early time after operation. Let's jump the more complex osteotomy. This is pedicle substruction osteotomy. As you see, understand from the name, we subtract, we remove the pedicle. It is basically like this. Through the pedicle, we make a triangle wedge-shaped removal, then close the osteotomy. So it will correct kyphosis to the less kyphosis if the pure deformity is kyphosis. If the pure deformity is kyphoscoliosis, you can do it with asymmetrical fashion. Then you can also correct the scoliosis at the same time. Its basic principle is a mechanic principle. Your anterior column here serves as a hinge. It should be intact. But it shortens the middle column. And of course, we remove the posterior column. Since we are dealing with the middle column, more bony part of the spinal column, it achieves more correction, and then you compare to the posterior osteotomy of the elements osteotomy. And if you are dealing with this ankylosing spondylitis, lumbar kyphosis, it's better to do in the segment which is horizontal to the sacrum, so you gain more lordosis gain at this part. Again, in fixed, rigid kyphosis and kyphoscoliosis, it is the simplest osteotomy that can be done. But of course, if the patient has some kind of operation before from the same area, severe osteoporosis, at that time, the correction, because we force more in this correction, osteoporosis is relative contraindication in this kind of patients. This is a technique. Of course, first we remove the postural elements, spinous process, lamina, like a classical laminectomy, let's say. And through the pedicle hole, actually, this is what we call decancellation of the vertebral body. It's not somewhat, this is, you see, after removing the posterior elements and lamina, through the pedicle wall of its lumbar spine, you can retract the dura, of course, you know. You see, this is the head, this is the tail, this is the pedicle hole. Either burr, osteotome is an angled thread, whatever you are familiar with can be used. Of course, the burr is the best option because it bleeds less, because it is spongious bone, it can bleed. After removing all this pedicle, and if you are sure enough to reach the anterior cortex, please leave the anterior cortex intact. Otherwise, you cannot close. As you can imagine, if it is not intact, if you close it, it will open. So it will not shorten. In contrary, it will elongate the spinal cord, which is dangerous for the neural elements. Actually, it does the correction at the 3 column, although the anterior column is left intact. Most of the anterior column is also decondylated. And second good thing related with this osteotomy, good healing potential. There is no metal inside, bone-to-bone contact, and also the cancellous bone contact, which is the most available the bony tissue for healing. And as you decrease the column, there is no tension on the vascular and visceral structures. But if you do not intact in the anterior column and cannot use like a hinge, then of course, as you can imagine, from there will be a tension in the anterior vascular structures, especially in the lumbar and inferior vena cava and abdominal aorta, and also visceral structures. You see, from the both sides, of course, by preserving the nerve root, retracting the nerve root, it's very easy to do flexibility. Even now, you see there is some movement of the, let's say, this is the wedge-shaped ideal one. And after placing a pre-bent lordoting as your desired length, the curve to the rods, you see this is very, very, very flexible, just by hand now. There is a temporary rod in one side. It is necessary, otherwise it can do translation. Then while holding the temporary rod loose, the final rod here, then do the compression. Sometimes if you do the constellation more, after final correction, you can see some gap in here. According to the size of the gap, you can put allograft here, or if the gap is more, you can put some small titanium mesh cage, which is also can be done during the osteotomy. And as you see, it is more stable. Let's see some case examples. This is the revision case, round kyphus scoliosis. Pedicle subtraction osteotomy at T8 level. It's not common. I don't like so much to do pedicle subtraction osteotomy in the thoracic spine because it's not so flexible. But in lumbar spine, its results are perfect, and these patients needs 2 level. In the thoracic spine, doing posterior vertebral column resection, I will show the example. It's more easy to me because you can sacrifice the nerve roots, you can get a more area, and you can get more flexibility and more correction. But pedicle subtraction osteotomy can be done in the thoracic spine also. Another example, kyphus scoliosis, 19 years old, quite stiff. Of course, this anterior support is questionable because since the patient is young and posterior fusion in the pedicle subtraction level, actually there is no posterior element. So anterior fusion, some authors advise, some are not. But if you have possibility, if you have enough facility, it's better to do anterior fusion also. Also, pedicle subtraction osteotomy can be done in degenerative deformities in the elder age groups. This is 56 years old, degenerative lumbar spine, lumbar kyphosis, which is a main cause of the mechanical back pain. Although there is no nerve compression, the patient suffers from severe back pain, which is not responsive to the conservative treatments. then to correct the sagittal plane, which is very important in the spine, more important than the coronal plane, pedicle subtraction osteotomy done in the L3 level is option to gain lordosis and to make a more straight spine. Of course, pedicle subtraction osteotomy is life-saving in ankylosing spondylitis. These patients suffer strong pain and disturbance of the body, the shape, and quite stiff. There is no mobile segments. And with the help of pedicle subtraction osteotomy, the horizontal gaze, the feeding, the drinking water, and looking out directly the sites in front of them is easy with the pedicle subtraction osteotomy. And these patients, you see, when the global thoracic and lumbar part goes in the kyphosis, the cervical spine try to decompensate to make a more flexion, more extension, but this more extension can cause muscle pain, and unfortunately, later ankylosing spondylitis also holds the cervical spine, and these patients even cannot look forward, and it's very painful, very debilitating, disabled life. And this pedicle subtraction osteotomy here, you see we put a cage, is the life-saving method. This is another revision case, ankylosing spondylitis. Somehow get on surgery, but it's a unsuccessful surgery. The progression is continuing. The patient comes here like this. He cannot look forward. The old life he's looking on the top of the heel, the foot, and this is the two-step surgery. One step is all through this revision case, aseptic discitis, pedicle subtraction osteotomy here, L3. You look the difference, and also the one pedicle subtraction osteotomy here, thoracic. But as you can see, the benefit of the PCO in lumbar spine is more than in PCO in thoracic spine. And the third osteotomy is the disc bone resection. Disc bone resection, you see there is a nerve root arising from just beneath the pedicle, and one nerve root is from here. So there's a wide, safe area. So instead of pedicle subtraction, we can do this kind of disc bone resection. It gains some kind of flexibility. It changes according to the needs, and compress, close it. If you do like this, you can gain like pedicle PCO range. If you do more, you can do more degrees. If you can do both disc bone, especially in the lumbar spine, you can retract the nerve roots so you can gain more safe place. It gives up to 60 degrees correction in the spinal column. Unfortunately, I have no video related with this, but I have some case examples. This is a degenerative lumbar kyphosis. Here, the problem is here, the disc space. So instead of doing pedicle subtraction osteotomy here, doing disc bone resection is more logical. That this is the result after the disc bone resection. Again, ankylosing spondylitis, the problem is aseptic discitis. That means there is discitis. You have to remove the disc. At the same time, you have to correct the deformity. So instead of pedicle subtraction osteotomies here, which we done in the other patients, in aseptic discitis, disc bone resection is more logical to remove the diseased disc part, and second, to correct the deformity. This is one of my friends, the medical doctor. This is preoperative and postoperative clinical pictures. Again, in post-traumatic kyphosis, this logic can be applied, disc bone resection, even in the upper thoracic part. Yes, the final part of, I think, according to the most entertaining and most difficult, but most challenging, but most useful part of the osteotomies is posterior vertebral column resection. I have enough experience related with this. We have published several articles related with this. Posterior vertebral column resection, as you can imagine from the name, removal of the whole vertebral column from posterior root. Normally, when this technique is first described, we call it vertebral column resection. That means posterior and anterior combined surgeries. But I can easily say that throughout my experience, my anterior surgery experience are very low because you can do everything from posterior, even in thoracic spine and in lumbar spine. In the tumors, in the infections, in the tuberculosis, spondylitis, most of the thing, osteotomies, correction maneuvers, removal of the disease part from the spinal column can be done from posterior. So posterior vertebral column resection serves this function actually. This is my. Let's start with one case example. This is 17 years old, the male patient. You see the X-ray and the appearance of the patient from front and back. Now it's quite rigid. So with knowing our known methods, it will be impossible to correct this and make a balanced spine. So we have to do something to give flexibility to the spinal cord. Now I will explain the steps from one by one from the videos. Of course, we first expose. The exposure of these rigid curves is somehow more challenging than the normal curves, but the basic principles are same. The second important thing, facet resection, we are doing non-routinely, but in this patient, facet resection should be done more widely. Not only fusion area, more importantly, give some kind of flexibility, which is not enough only alone, but it helps. Pedicle screw insertion is more challenging in this group because somehow you have to do more medial, more lateral, which can be you a bit a little bit making afraid if it's in the wrong way or not. One trick you can do this in under fluoroscopy, but which is more radiative way. Second thing is if you have navigation type of systems, but in the brackets in navigation system, most of the navigation systems are calibrated according to the normal the spine. So in the severe rigid curves, somehow they can make a surprise to you. And the third thing is my way is to memorize the X-ray, try to place pedicle finder to be on the lateral side. In most of the level, especially in the apical level, I'm first violate the lateral wall that I am sure that I'm in the medial, then make a more medialization and put the pedicle secure. Because lateral wall is the weakest wall of the pedicle. If your pedicle is enough inside the vertebral corpus and the intact medial, superior, and lateral wall, the absence of the lateral wall is not so important actually. This is the apical part, and your apical screws should be most powerful one. And since this deformity spine has very narrow pedicles, you have only one chance. So pedicle screw insertion is, I think, half of the operation. I say half because in some of the patients, this exposure and insertion of the pedicle screw steps takes more than 4 or 5 hours. I'm usually divide the operation into half. At that time, I finish the operation, close the patient, and a couple of days later, again reopen and start with osteotomy, which takes extra 4 or 5 hours. After inserting the pedicle screws, we determine, of course, the posterior vertebral column resection plant level. We don't place any pedicle screws. So after this plan, we, after placing the pedicle scripts, we make a temporary rod in the level. Normally, I'm starting with the, sorry, this is head, this is tail, this is the convex side, right side of the patient, and I'm here. I usually start the osteotomy from the convex side. It's a preference, it's not a rule, but in convex side, you are quite safe when you compare to the concave side, because the spinal cord is deviated to the convex side, concave side, but in convex side, it's a little far from the spinal cord. First this. Second is the anatomy is more open to you, more bone. And I'm first, after doing wide laminectomy means not only the osteotomy plant level, one level above and one level below, because when you close the osteotomy, you make a very good correction. If you do only one level of laminectomy, the spinal cord can kink, and the edge of the lamina here can compress the spinal cord. Your laminectomy should be as wide as possible. This is a spinal cord, you see? This is the spinal cord, and this is the area. This area is quite safe. You see the spinal cord, and through the corpus in the intervening disc spaces above and below, you can easily remove it. But before it, when you do laminectomy and do the laminectomy in the lateral side, you will face the nerve root. And thoracic nerve root are not in like a lumbar nerve roots. You cannot retract so much, but good thing, you can sacrifice it. So cutting the nerve roots in one side, even in both sides, even the cutting for more than one level, except a kind of numbness in the body, nothing happens. So you can safely, easily cut the nerve root. Then use I'm using high-speed drill. Some surgeons prefer osteotome, but it's a little bit bloody. You can do the white laminectomy. You see here, I'm finding the nerve root with the right angle tip instrument, then make a silk suture. I fix it both in the proximal part to the spinal cord and the distal part through going to the intercostal muscles. As I said before, between T2 to T10, some literature says T11 is awesome. You can easily sacrifice the nerve roots. It creates a very wide window to you. You see, this is the proximal part. I make a suture. Now I'm finding that this is the nerve root, thoracic nerve root. Again, I'm repeating, this is head, this is tail. I'm in the right side of the patient, and the curve is like this. I'm in the convex side. This is the spinal cord after wide laminectomy. This is the screw. One level is empty. We will do the osteotomy at this level. Okay, this is the one suture here, one suture distally, and between it, first I'm burning it with the bipolar cautery, then similar cutting with the scissor. I see here. After laminectomy, the burr you will face with the nerve root and sacrifice the nerve root. Cut with the bipolar cautery. And cutting. So now is a spinal cord with the cut nerve roots here. So this area with the laterally is a pleura, medially in the spinal cord, you have a safe window. Then through this window, you will do osteotomy. This is head, tail. This is the spinal cord. This is the other side, concave side. This is the convex side. So leaving the posterior wall a little bit just for the safety margin. Use burr, high-speed burr to I will complete the wide laminectomy here. Because dural impingement is the mostly seen the problem after correction in terms of neural element compression. So we should be alert about this. I'm removing the rib heads. Now this is spinal cord here. There's a wide, since it's a convex side, actually it is rotated. So it is in the vertebral corpus is actually, it's in front of you. So the remove it with the burr or osteotome or even a punch is somehow quite difficult. The important thing is here is we have to remove also disc space, and disc space is quite degenerative, so removal is not so easy at all time, but it can be done. Now, after remove the nerve roots, the laminectomy, we are putting a marker to see the exact, to see the fluoroscopy in the lateral view, to see the exact position of the disc space. Now this is the exact position of the disc space. Then we will check the direction of our markers. Then start with the osteotomy. Please in mind, there is temporary rod here. Always should be. And do the osteotomy with burr, osteotome, it's up to you. And removal of the old disc material in the up and down with the intervening bone, leaving the anterior cortex like a shell. You know, in the anterior cortex, there is a thick, strong anterior longitudinal ligament. If you do this osteotomy with burr, when you come to anterior cortex, the burr, the feeling somehow it makes softer. Then you can imagine that you are now in the anterior longitudinal ligament. The desired stopping point is like this. If you cannot feel the term in the beginning part of the your practice, you can make a marker and put the fluoroscopy that if there's still anterior cortex or not. Because if you not remove the anterior cortex till the anterior longitudinal ligament, it will not give enough flexibility, so your correction will be less than normal. And when we complete the osteotomy in the convex sites, again we place the rod here, and I put a lot of surgical insights. Then do the same thing, same procedure from the concave side. In the concave side, there is less bone. There is more medial you should do. And when you, sometimes you don't need to sacrifice the even nervous since you will work in a limited space. What we are doing in concave side osteotomy, in the concave side osteotomy, there should be a continuation of the osteotomy. Most of the corrective maneuvers is compression, as I said before in the osteotomy, should be in the convex side. So in the concave side, it's enough to meet with the osteotomy other side. That means while doing the osteotomy in the concave side, if you find the surgical that I put in the other side, you will be the happiest person in the world at that time. It means your connection is established. At that point, there is only posterior cortex remained. This is the most challenging part of the surgery. Posterior cortex should be thin enough. If you make it thick enough, leave it. So with the help of the reverse curette, we are trying to remove the posterior cortex. It will be need more force with the hammer. So every trauma make a spinal cord the injury. Fortunately, this kind of injuries, most of them are temporary, but we have lived also experienced this kind of problems. So if you are sure that this is the thermal or any other this hammer injury, at that time, in my practice, I'm starting the bolus dose of steroids. Then maintenance dose, and wait at least half an hour, do nothing, and wait for the neuromonitorization. If your neuromonitorization is not reliable or is not say anything, but if you are sure that you are okay, at the same time in the operation, wake-up test is the gold standard. But wake-up test is very difficult for anesthesiologists to make it every time. So at least half an hour. Sometimes we waited for 1 hour for the disappearance of these effects of this trauma and the spinal cord problem. Normally, spinal cord, when you directly hit or is injured with the pedicle screws, it is permanent. The problems in the during the operation, most of them are temporary. But in our the series in the literature, although it's temporary, its rate is around 25%, which is a quite huge range. And the second big the problem when the any neural temporary or permanent injury occurred, you cannot stop the surgery. You cannot go back. You have to go forward. So without this suspicion in your mind, doing the surgery, you know better than me, it's not a good thing. So we removed it, all of them, resect vertebral body, remove the posterior cortex. So 360 degrees removal of the vertebral column, both 3 columns. That means the vertebral column resection. The only thing that we maintaining the correction between the upper and lower part is your rod and spinal cord. This is the only bridge. So you can imagine how your temporal rod is so important, because if you remove this rod, is direct the spinal cord is transected. And second challenging part is correction. Yes, it's very, very, very flexible because there is no connection with the upper and lower part, and very flexible. And this part is very prone to spinal cord injury. So your correction maneuver should be more and more gentle than the normal correction maneuvers. As I said in the beginning of my osteotomy section, global derotation or any derotation maneuver is strictly forbidden in osteotomy. If you do the rotation correction in the upper part and lower part, you cannot control. And it's like a twist motion. If the upper part is more or the lower part is more, spinal cord is twisted, this is permanent spinal cord damage and paraplegia. It cannot be reversed. So the only thing that we can do is cantilever. Cantilever means one is halfly fixed to prevent this rotation and translation, and the place rod, adjust the rod into the concave side. Again, start from the concave side. I'm mostly start from the, not in this figure, it starts from the distal to the proximal. But if the kyphosis component is more, and most of the patients has kyphoscoliosis patients are kyphosis component is more, it's better start from the proximal part and adjust the rod inside, and by maintaining at the same time both kyphosis and scoliosis. Another trick, I'm using always long arm, what we call reduction screws, because the lumbar spine somehow is more flexible in terms of anatomical structure. So when we fix the upper part and close osteotomy, to adjust the rod into the long arm screws is better. Another trick, start not the uppermost vertebra, start, that means to place the set screws, start from here. Because if you start from here, most of the tension will act on this facet joints. The upper part is, there is no instrument. So proximal junctional kyphosis, even in T2, can happen. But if you start from here and not put set screw firstly here and do all correction maneuvers, pushing, adjusting to decrease kyphosis, all the tension will act on this facet joint. So since it will be in the fusion area, the proximal junctional kyphosis will not be the issue. And after adjusting this with insider bender, sagittal insider bender, or for coronal bender, you can adjust like this. At the same time, do the compression. Always do compression in the osteotomy. Distraction distracts the spinal cord. You can do somehow distraction with insider bender, but not in distractor. Always do compression. It will also compensate the whole body balance. And compression in the here, in my practice, I'm putting the rod first. It somehow partially close the osteotomy sites. Then put the mesh here according to the gap. Then after putting the mesh, do more compression to squeeze, to compress the mesh, which will be the fix. It is very, very difficult to make a bone-to-bone contact. If your correction is bone-to-bone contact, and if your neuromonitorization says, okay, it's not PVCR, it's bone-to-bone resection. If you are sure that you are removed the disc and bone-to-bone contact happened, then your neuromonitorization will say bad things because the kink is obvious. So the kinking of the thoracic spinal cord is equal to paraplegia. From the convex side, with a mesh cage, additional final compression to secure the position of the mesh cage. Excessive compression we have to avoid because although your pedicle screws are strong enough, doing osteotomy, while doing osteotomy, you can make a weaken the inferior wall of the pedicle. So if you do more compression, it will pull up, so you can lose this compression anchor point and you can injure the spinal cord. Second, if you do more compression, the kinking is important, and then it causes a neurological problem. And after final correction, although we made a wide laminectomy before, we have to evaluate the spinal canal at the edge of the laminectomy site, although the neuromonitorization says okay. The basic rule in this kind of surgery, don't trust anyone. You have to convince yourself that there is no any point which is still compressed, because sometimes neuromonitorization says okay, but the clinic can be different. And this is the result after operation. You see the mesh cage in the PVCR osteotomy sites. And this is the preoperative and postoperative early clinical pictures. Of course, in these patients, when the muscular healing will establish, and after 3 months, we start the muscular exercises after the establishment of the fusion, the final position of the body will be more clear, more true. So in the first times, I'm always convinced the patients this is not the final position of our body. Important thing is the X-ray. If the X-ray is balanced, don't worry. When the muscle reshaped, because they are used to be shaped in this scoliotic position, when the muscles are reshaped and strong enough, your body appearance will be better in the future. There are some case examples. You see, 16 years old, rigid. Also rigid here, it's less than 50%. So without osteotomy, it's impossible to make a correction. This is, for example, I wrote PVCR with bone-to-bone contact. Probably it's not PVCR, but you know, it's some congenital problems. There are some fusions in the vertebral bodies, no discs. So it is somehow between vertebral column resection or bone-to-bone resection. This is T9. This is before and after operation. Again, some kind of this. Sometimes it was very popular. I didn't use, but these rib instruments to arrest the growth in the concave side, convex side. But of course, it's not works. Today, I think there are no in the market, but 10 years ago, they were very popular, and most of the patients are unfortunately have got this kind of operation. This is a rigid scoliosis, is 9 years after osteotomy and closure. This is the preoperative and postoperative. Still, scapula is a little bit higher. 10 years, the congenital problem. The PVCR, posterior vertebral column resection, is most effective in congenital problems because we are 100% sure that they are rigid. Another patient, 20 years, severe scoliosis, you cannot differentiate the vertebral bodies, CTs, MRIs, and you see the mesh cage here, the correction of the deformity. Of course, I'm always saying to patients that they are normally worrying about how much percent it can be corrected. The real answer of this question is at what percentage your spinal cord will allow this is your correction percentage, because we can correct 100% if this spinal column cannot carry spinal cord. So in neuromonitorization, then the patient's spinal cord, the condition of the nerves will decide how much percentage correction will be achieved. This is the end results after operation, the clinical picture. Again, these two are in open access in spine websites. It's one of the huge PVCR series. It's published in 2012 and 11. Now, at least this number doubled. Another challenge is the presence of infraspinal abnormalities. The neurosurgeon colleagues are more familiar with this kind of abnormalities. Of course, it makes more challenging and more complex a situation. Although there is a rigid, very bizarre deformities, patients are coming by walking, and they expect to be straight without losing any functional abilities. We are doing routine MRI and CT examinations and find any intraspinal abnormalities. Use of the incidence can be reported in very wide range. It's kind of Chiari malformations, diastematomyelia, fibrous or bony spurs, the tethered cord. They are very important abnormalities. Normally, they stay silent, but when you change the dynamics and vascular supply of the spinal cord after correction, these silent abnormalities can be important, but sometimes they are not so important. So in which patients we have to do this, we have to solve the neurosurgical procedure and of these intraspinal abnormalities. They carry their own risk in terms of neural damage, either tethered cord or diastematomyelia or unnodcular malformation. So if we do surgery in this part, in which part of the whole total scenario these neurosurgical procedures should be placed? First, do the intraspinal anomalies, then later on in corrective surgery. If yes, how long it should be into operation? If you can do at the same time, it's normally this osteotomy takes long time. Another intraspinal anomaly surgery will elongate the surgical time. Is the anesthesiology team is okay? If the intensive care is a lot of questions, so it's a very big challenge. So we also always perform neurosurgical and critical surgery at the same time, if possible, because if the common recommendation in the literature, do neurosurgical intraspinal abnormality surgery first, and wait a couple of months, do the corrective surgery. It is somehow is not logical according to me, because first, for example, tethered cord can do retethering during this time. The second, a couple of months later, corrective surgery, when you expose it, all the anatomical markers are somehow change. So the best thing is to do at the same time. We have published this in Spine. It's a very the old times. First, doing exposure, placing the pedicus screws, do the neurosurgical operation, then osteotomy and correction. In the tethered cord and Arnold carry, neurosurgical operation is quite easy, not time consuming, so not so make a longer the operation. The problem is here diastematomyelia, the excision of the bone superior. It takes time and risk, but fortunately the diastematomyelia area is almost all of the patients in the apical regions. That means we will do the osteotomy at the same level. So actually doing the bone superior resection somehow is our start of our osteotomy section. So in diastematomyelia, we can easily continue to the osteotomy. So our recommendation is to do at the same time. This is tethered cord. You see the diplomyelia, congenital scoliosis. She had operation previously. This is a normal standing position of the patient. This is after operation. Diastematomyelia superior, tethered cord release, and osteotomy and correction. Again, another patient, 13 years, tethered cord, congenital scoliosis. Actually, it is lordosis, a little bit lordosis component is also present. And this is, you see, interspinal abnormalities, tethered cord release, vertebral column resection. You see the mesh cage here in T10, T11 level. In T10, T11 level, you can sacrifice to T10 nerve root. All of them were done at the same position. Okay. Basically, this is my lecture. Now we have time for question and answers related with these issues or related any other spinal the problems or questions with the continuation of this kind of the educations, either online or in terms of short-term or long-term the fellowship, and also I think for the academy, the heading of the academy, we will have 6 more education program, not only spine, also other subspecialties of the orthopedics. Yes, I'm waiting for the questions. I feel myself alone to Moderatör arkadaşlar, ne kadar bekleyelim? Ben bitirdim ama hiç soru gelmiyor.